Hi, this is Bob Harrington from Stanford University, bringing you back to the Heart of Cardiology, sponsored by Medscape and theheart.org. I'm really excited to have this series of podcasts where we can set the stage for some of the conversations we're going to have in the conference in December. And in this particular one, we're going to talk about an important group of patients, that group of patients with heart failure with reduced ejection fraction. I'm pleased to be joined by my friend and colleague, Dr. Javed Butler, who's a professor and chair of medicine at the University of Mississippi Medical Center in Jackson, Mississippi. Javed, thanks for joining me here on the Heart of Cardiology.
Absolutely, pleasure to be here.
Javed, I was paying attention to what was coming out of the Heart Failure Society of America conference a few weeks ago. And I have to say, as a non-heart failure expert, it's getting complicated, isn't it? Multi-drug therapy, new drugs. And so I thought what we could do on this podcast is really have you walk us through the approach to the patient with a reduced ejection fraction, meaning once you've made the diagnosis, you've looked for whether or not you're going to revascularize that person. What are the medical therapies that people should be thinking of? And let's talk about this concept that's really being pushed by the heart failure community of let's not do stepwise therapy, one medicine at a time. Let's think about getting people on all of these medicines all at once. Can you start with what medicines are available before we get to the true evidence-proven ones before we get to the new ones?
Yeah, so this is really great time to be practicing cardiology and heart failure. We have so many positive trials and so many things that we can do to our patients to improve their outcomes. So you already alluded to the fact that we have to take care of specific etiologies. So if somebody has ischemia and needs to be revascularized or have hypothyroidism, but after that, if somebody has sort of persistent low ejection fraction, at this point, the guidelines are moving in the direction of quad therapy or 4 drugs as baseline medication foundational therapy for these patients. Now, there's a lot to unpack here, but it's basically ARNI, evidence-based beta blockers, evidence-based MRAs, and evidence-based SGLT2 inhibitors are the foundational therapy for the management of patients with heart failure and reduced ejection fraction. But there is a lot to be discussed. What is heart failure with reduced ejection fraction? And how do you use these therapies and how do you initiate these therapies? But fundamentally, this is where the field is today.
Yeah, I mean, I've been impressed by a couple of things. Number one of which is the efforts to which the heart failure community has gone to gather large-scale patient outcome-oriented data. Most of these trials have endpoints of mortality and or hospitalization for recurrent heart failure. Do you think that that's a good starting point, that we really should be looking for the therapies that reduce death and or reduce the risk for hospitalization?
Yeah, certainly. So, quality of life is really, really important to our patients, and we should always keep that in mind. But at least so far, all the medications that improve mortality, morbidity outcomes also have eventually benefits and quality of life as well. So these things all sort of go hand in hand. But correct that as opposed to certain things where we might have some faith without data, over-the-counter medications and those kind of things, we now have such a large evidence base with multiple rigorously controlled clinical trials that I think reaching out for those therapies, not only reaching out for those therapies, but reaching out for them as soon as possible because time matters and at the appropriate doses is the sort of the charge performer for the clinicians now.
So, Javed, help as you know, I'm an interventional cardiologist who now practices largely general cardiology, and help us understand how to do this. Is it to go right to maximum doses of all of these medicines? Is it to start all of them at low dose and titrate them all concurrently? What should we do? Give some advice to the general practitioner out there, primary care doc, general cardiologist, who's trying to manage these patients.
Yeah, so I mean, actually, it's really, really simple, right? Sometimes we sort of make things a little bit more complicated than they need to be. So first, let's realize that the sequencing of these therapies is a historical construct, not a biologic construct. It's history of medicine that in the 1980s, we were looking at ACE inhibitors, and 1990s beta blockers, and so on and so forth, SGLT2, ARNI, so on, so that progression, there's no biologic reason that you have to prime the heart with one medication first before you give the second medication to get the benefit. So that's sort of one concept. The second is that dose is very important, but blocking the pathway with something is more important than dose alone. And that the place where it becomes important is that sometimes if you maximize the medications at higher doses, you may run out of your spending function, for instance, with blood pressure or hyperkalemia or something else that you cannot give another medication. So the first order of business is to cover all relevant pathways at low doses, and then certainly if the person has tolerability to go on higher doses, then definitely go on higher doses. And lastly, also remember that this dose issue is only for ARNI and beta blockers, 25 milligrams spironolactone and 10 milligrams of an SGLT2 inhibitor, empagliflozin, dapagliflozin. There is not a whole lot of dose issue there. So get the medications, get soon as possible, but at least low doses to cover all pathways that modulate worsening heart failure. And after that, if you take some time to up titrate, that's reasonable.
And what kind of conversation do you have with your patient? Sometimes we're negotiating to start another medicine, to add another medicine. How do you present it to your patient? Look, I've got to get you on these 3-4 medicines now, and we'll work to increase the doses over time. Give me your script.
Yeah, so I don't want to make light of either of the two real issues, right? So one is cost and inconvenience and polypharmacy. Those are real issues that we need to contend with. Also, side effects and management of side effects is also something we have to contend with. Having said that, we cardiologists really need to get a little bit of a mindset of oncologists, right? So we all say that heart failure has equally as bad a prognosis as many forms of cancer. Yet let's just think about how our oncologist colleagues think. First, they say that the combination of XYZ medication gives the best outcome. So the mindset is not, let's just give X, see if the cancer progresses or not before we introduce Y. The whole idea is to prevent worsening by the best combination up front. And two, talk to the patient so that they expect what side effects may occur and then figure out ways to enable those therapies and deal with the side effects, because mortality, morbidity reduction is sort of the prime aim. Now, again, I really want to highlight that I don't want to make light of side effects and give an impression not to worry about that. But as opposed to oncology, I mean, we are talking about side effects of potassium of 5.2 or some dizziness that we have tools to manage. We can give medications at different times of the day. We can cut down on diuretics. We can cut down on certain medications that may not be very beneficial. But if you explain to the patients what to watch out for, what the benefits are, and I mean, I can tell you, our patients are really smart. I mean, you just spend 5 minutes with them and they just get it. And then their adherence and compliance with your recommendation increases because now they are part of the team and they are playing the game with you.
Great description. Let me talk about some of the specific medicines. The ARNI, certainly the valsartan sacubitril combination proved superior to the ARB alone. Should we just, that's the starting point now. We shouldn't even go with the ARB and ACE inhibitors. What about if our patient's on an ACE inhibitor or an ARB and are tolerating it well? Should we make that switch as at the time that we're trying to get them on the evidence-based beta blocker, SGLT2 inhibitor, et cetera?
So sequencing doesn't matter whether you put them on beta blocker first and then switch the ACE inhibitor to ARNI, or first switch and then start beta blocker, and maybe we can have a little discussion on the sequencing issue. But the bottom line is that yes, even if that person is quote unquote stable, I would still switch that patient from an ACE inhibitor to an ARNI. There's a little bit of a difference because you don't want to give ACE inhibitors and ARNI overlapping because of the risk of angioedema. So you have to stop ACE inhibitor for 36 hours before giving an ARNI. whereas with an ARB, you're basically exchanging one ARB for another so you can switch right away. But another fundamental way of thinking about it is that ARNI is really two drugs combined into one. It's not like just some super RAS inhibitor. So if somebody is on ACE inhibitor, but then there was a beta blocker was only available as a combination with an ARB, one would never say, let's just give ACE inhibitor, that's good enough, right? I mean, you want to introduce beta blocker. So similarly, you want to introduce neprilysin inhibitor. That's two different medications combined into one. So no matter how stable the patient is, I would convert them from an ACE or an ARB to an ARNI.
Good advice. And I particularly like the caveat about angioedema when switching from an ACE to the ARNI. Really good clinical pearl. The SGLT2 inhibitors, many will think of these as diabetes drugs, but they're not just for diabetes, are they?
Yeah, so if you look at the pharmacodynamic profile of SGLT2 inhibitors, the cardiac structure and functional benefit, the vascular structure and function benefit, the renal benefit, and then the systemic benefits, they clearly, I mean, if a drug can do these things, then you can certainly expect benefit in non-diabetic patients as well. So now we have 4 trials, 2 in heart failure with reduced ejection fraction, 1 in CKD, and 1 in heart failure with preserved ejection fraction, where the presence or absence of diabetes did not matter. You got the clinical cardiovascular benefit with these agents. So yes, these are good anti-diabetic agents. Yes, they were discovered first for the management of diabetes, but they're truly cardiovascular risk modifying agents and should be thought of as such.
Yeah, that's a really good description. And it is something that I think we need to continue to do education on, that these are not drugs exclusively for diabetes. Yes, that may have been the starting point, but as you've noted, they do have important cardiovascular physiologic effects, and let's make sure we're using them in keeping with the evidence. Okay, now let's take the situation, Javed. I've got my patient on the evidence-proven medications. They are doing okay, and then they have an episode of decompensation. There's new drugs that are either on the market, new approaches that are available, for example, potential iron transfusion. Where are we with thinking about the decompensated patient who had already been on maximal evidence-based medications?
Yeah, so that field is sort of really evolving. So at least the first thing I would do is to just see whether decompensation was related to something which was clearly evident. In other words, this person doesn't have worsening heart failure. This person is not sort of failing from their standard medical therapy. So if somebody went on vacation and forgot to take their medicines and have been out of pills for a month and develop worsening heart failure, that's a different thing. They need to go back on their medication. So that's a different category. But assuming that they have now been on stable medical therapy, had been kind of sort of doing okay, but now they are not, and they come back into the hospital, let's just realize that these patients are at a particularly higher risk. We're talking about an excess of 20-25% one-year mortality and an excess of 50% 6-month readmission rate. So this is not just that you gave some diuretics and they got better and that's all there is to it. So there are certain things that are in order. So again, take that as an opportunity to really look at the patient overall, just make sure that there's no other reason why this patient went into decompensated failure, atrial fibrillation, new ischemia related issues, hypothyroidism, whatever have you. Assuming that all that has been ruled out and the main issue is progression of heart failure per se, then there are several opportunities now available. There is a trial done called Victoria with vericiguat, a soluble guanylate cyclase stimulator, a 4.2% absolute risk reduction in cardiovascular death, heart failure hospitalization at 1 year, 10% relative risk reduction. So introduction of vericiguat would be very appropriate. A little more than half of these patients are iron deficient. Regardless whether you have anemia or not, iron replacement has been associated with substantial reduction in readmission in these acute heart failure patients. There's another trial with omecamtiv mecarbil. It's not available in the market, have not gone through the regulatory process, but it's a myosin activator, so it increases cardiac contractility, and especially those patients with low ejection fraction, less than 28-25%. The benefits were impressive with these agents also. So perhaps in the future, that could be one option as well.
And so again, I like the way you've walked us through it. Check for iron levels, check to see, therefore, if patients might benefit from iron supplementation, move to newer therapies. You've told us about at least one that's not yet approved, but is but is coming, presumably based on the strength of the clinical trials evidence. Other things that they should think about. How about this question for the generalist? When does somebody like me refer my patient to somebody like you for even more advanced heart failure therapies, including mechanical support, bridge to transplantation, consideration for transplantation, et cetera?
Yeah, so I mean, there is probably a little bit of a regional answer to this and how accessible are heart failure programs. And the reason I say this is that if accessibility to a specialized heart failure center is not readily available, then perhaps, you can have some trigger terms, right? So a person is failing standard therapy or has a low blood pressure or a high creatinine or some reason where a non-heart failure specialist is feeling uncomfortable taking giving the therapy, recurrent hospitalizations, intolerance of medical therapy. All of these things will sort of indicate that the heart failure is advancing and that perhaps other alternatives like device therapy or transplantation should be considered. Having said that, if the heart failure program is somewhat accessible, an earlier referral, at least even a one-time referral so that the patient is in the radar screen, and even if they are seen by a heart failure program once a year and is managed in the general practice setting, is really good, because one problem that we consistently see is that by the time patients are referred to us, they're appropriately sick, but unfortunately they're too sick and they've developed something, irreversible pulmonary hypertension or something or the other, that they are not candidates for advanced therapies, whereas if they would have been referred about 6 months earlier, maybe they would have. So depending on the availability, but bottom line, if a person is not doing well and we are unable to treat them in the general setting, just refer those patients.
Javed, this has been a terrific discussion. You began with walking us through the foundational therapies, including some important new concepts of getting all the medicines on quickly rather than a slow sequencing titration. You've talked to us about the notion of making transitions from ACE inhibitors and ARBs to ARNI. We've talked about SGLT2 inhibitors and the emerging data with their benefits outside of the realm of diabetes for which they originally developed. And you've walked us through some of the new concept and the new therapies that are either available or we hope will be available in the coming years. And finally, you've helped us understand who we might refer to advanced heart failure care. I can't wait to have these more detailed discussions in the Heart of Cardiology conference. I hope our listeners will join us. And I want to thank you, Javed, for all you're doing for the field, moving the field forward. And thanks for joining us here on Medscape Cardiology and the Heart.org.
Absolutely, my pleasure. Thank you.